Welcome to Beyond the Box. There is a moment every parent experiences, a moment of quiet suspicion, that nagging feeling that something is a little different with their child, the sleepless nights of searching, the endless questions, the fear of what's to come. Today we have a guest who has been on the other side of the journey, guiding families over a decade. Dr. Tumelo Leeuw is a respected pediatrician, a neurodevelopmental expert with over 10 years of experience, and an advocate for people with disabilities. She's here to turn the clinical expertise into a trusted guide for you as a parent who's searching for answers. Dr. Tumi, thank you so much for being here with us. It's such an honor.
Thank you, Emma, for inviting me. It is also a humbling experience to be here with you guys.
Dr. Leeuw, let's start where most parents start. And we found that the most Googled question in South Africa right now is, what are the signs of autism?
So let me just start by telling you a funny story that I have recently experienced. A mother with a 1-year-old came up to me and she's asking, Doc, my baby is flapping his hands. Should I be worried? Is that autism? So because of the amount of awareness that has been created about the condition, now everybody wants to believe that they can diagnose it in their children simply because they've heard of some of the criteria that we've mentioned. So
are you saying that people know about autism already?
A lot of people. I mean, over the past few years, we've really done a great job of spreading the message and creating awareness about autism. So there are a lot more parents who are aware, but now the problem is everybody is over-diagnosing that their children might be on the spectrum as well, so which is not necessarily the case.
Absolutely. So it's parents at home saying, this is what I'm seeing. I had Dr. Leeuw talk about it. You know,
caregivers, grandparents, aunts, or people who in the community who see somebody's neighbor behaving in a certain way. And they say, but those are some of the signs that I've heard being mentioned are for autism. So therefore, this child must also be on the spectrum.
Oh, interesting. it presents a very interesting, situation, actually, if I'm coming to think of it. Yeah. Because on the other hand, it means people are aware, which is a good thing.
Which is a very good thing.
When they see it, now I had Dr. Leeuw talk about this. However, the other side of the coin is the stigma.
There's still the stigma. So with neurodevelopmental conditions, unfortunately, there's still a lot of people who do not believe that they are actually medical conditions, but that they are actually a curse. The ancestors are not happy about something, or the mother did something while she was pregnant and therefore disobeyed cultural norms and things like that. So the stigma is still rife, even though there is a little bit more knowledge about it, even though there's a little bit more exposure and acceptance. So yeah, it's still a challenge that we're dealing with.
Yes, and I'm happy that you're bringing this out, especially in our Black communities, that this stigma can really cut deep if you're a parent that's raising a child who's neurodivergent, right?
And it doesn't just extend to where the diagnosis is made. Even after the diagnosis is made, there are still people who offer traditional remedies that are supposed to cure the child. Because I think once the diagnosis, at any diagnosis of neurodivergency, something that we'll talk about a little bit later, but any diagnosis that is concerned with neurodevelopmental disorders, obviously the parents are a bit stressed about it because for them it feels as though there's a deviation from the norm for their children. So after the diagnosis has been made, and obviously you also have the conversation that there is no cure, it's not curable. A lot of parents look for solutions that will fix their children because they don't want their children to be different from others. So you have people who will tell you about the prophet who promises to pray for them, and unfortunately, these parents fall prey to some of these schemes where money has also is also exploited basically. So there's these therapies, you bleach enema to help your child, or there's this medication that you can drink that detoxifies and removes certain elements from the child, and therefore the child is instantly cured.
Sure, that sounds a little bit more intense, Dr. Tumi, because I'm thinking, you've mentioned this awareness, but it seems like there's a lot that still need to get done. Because if people are now trying to cure and trying to fix, then that's a deeper issue because you're causing more harm.
There's still a lot of work that's still to be done. I mean, we have made a lot of progress. There's a lot of great organizations out there that have spread the word. There are a lot of practitioners. There's a lot more neurodevelopmental pediatricians now that have been trained that are practicing in South Africa. But it's still a challenge, especially because most of the diagnosing and most of the therapies were coming from overseas.
Oh, okay.
So when they come this side and trying to implement them as in the assessments, the diagnosis, in the therapies in our African setting, it causes a little bit of conflict.
It's a disconnect.
Because one of the things that I've noticed is that because autism does not have a vernacular name, there's no name for it in Setswana, in Sezulu, in Xhosa. So because nobody can put it into a language that they understand, it still creates that problem that it is not a condition that exists in the African culture. And it's something that, white.
Yeah, it belongs there.
More affluent people. So some of those challenges obviously do create the problem when it comes to when you do make the diagnosis, or when you have to tell parents that this is the diagnosis and going forward, this is how we're going to be exploring this journey. And that can make it a bit challenging for the parents to accept the diagnosis.
Interesting. What very important insights you're bringing out. And I think if there was enough time, and hopefully in the next segment, we could unpack some of those, the fact that it's a European situation. It's not ours, how do we deal with it? So going back, Dr. Tumi, to some of the signs of autism. I'm just curious, and I suspect maybe some of our parents are curious as well, whether autism presents itself differently in toddlers that would naturally show up in your practice versus in young adults, for example.
Primarily, autism is a neurodevelopmental condition, meaning that the child is born with it. And it affects the child's ability to communicate. It does affect communication, both verbal and nonverbal. It also does affect the child's behavior. As in, for instance, the child might have repetitive behavior, physical behavior, or even in language. There's something called echolalia, for instance, where they just keep repeating something most of the time after they're repeating what somebody else has said. And then there's the sensory element as well, where the child could be hyper or hypostimulated. So because of such, and depending as well at the different stages of development of presentation, for the little ones, most of the time when they present is because the mother has picked up that the child has not reached certain developmental milestones that are appropriate for that particular age, or the child did achieve them and then suddenly there's a regression. Meaning, for instance, at 18 months, the child was speaking, mama, papa, able to express themselves a little bit, and then suddenly they don't make any kind of communication. They don't want to be hugged, or they don't socialize the way normally a typical 2-year-old toddler would present. So because of those, we use certain criteria to diagnose it. And presentation obviously differs because it's a spectrum as well. So presentation also differs from one person to the other, and within the different age groups as well. It's not just a diagnosis that's made by one person. We try to use the multidisciplinary approach when we make an assessment, meaning that the speech therapist might need to be involved, the occupational therapist, the doctor, the educational psychologist. Sometimes you have to get a report from all of them to be put it together. It's something that is comprehensive. But clinically, we use something called the DSM-5, which is a book that is mostly used by the psychologists and psychiatrists, because it's got a criteria. So you just go through the criteria, and that's how you make the assessment of the diagnosis. There are other tools as well. We've got the ADOS-2, which is a clinical tool that we use to tick off. It has modules for different age groups as well. So that is quite effective, but not a lot of people are ADOS-2 trained. And then I think also one of the other things that is a big factor is where the child is presenting, or where the person is presenting, whether it's in public sector or private sector. So in public sector, obviously we lack some of the tools and the skills and expertise to be able to make the diagnosis regardless of the age. But in private sector, it might be a little bit easier with everybody being present.
Yeah,
then
the course, yeah. That's something
an influence. Yeah.
Sorry to interrupt you, Dr. Tumi, but that's something we need to cover. We need to talk about, because South Africa is a developing country and a lot of parents have this economic hardships that's involved. But I don't want us to unpack it now, because you said something that caught my attention, where you said autism might present itself in, you might notice a child regressing, a regression of behavior as they're growing up, right?
Regression of milestones.
There we go, regression of milestones. And some of the things we're hearing people say, my child was speaking, all of a sudden after taking injections at the clinic, they don't talk anymore. Can you speak to that?
Yes, there was that allegation, that myth that there was one of the vaccinations, one of the childhood vaccines that actually caused autism. But it was, I think that publication was retracted. And there was an apology as well, because it caused a lot of confusion for many years. But there are still people who still believe. I mean, there's conspiracy theories about everything in this world. There are still people who believe that the vaccines are a problem. And that's sometimes you may find there's certain groups that choose not to vaccinate their children because of those particular reasons. But no, at the moment, there is no vaccine that has been shown to cause autism or neurodevelopmental conditions, unless perhaps there was some comorbidity or some missed signs of that missed the development. I mean, the diagnosis as well.
Yeah, I'm so happy that you are clearing this up for us, because I'm really happy, because literally, as you say, it's a conspiracy theory. It hasn't been scientifically proven, and therefore it cannot be accepted to be a fact.
I think it falls also into that same group of some of the stigmas that we have out there. There are some people who would take some of this information and obviously mix it up so that they can be able to take advantage of parents who have not yet acknowledged or accepted the diagnosis.
Yes, maybe let's move on now. Now that you've unpacked what are some of the symptoms, what parents can look out for, as far as getting help to do a diagnosis for the child, as far as autism is concerned. Dr. Tumi, so many parents often doubt themselves. They can kind of feel that something is not quite right, but they aren't quite sure. A lot of doubt there. What do you say to a mom or a dad, or maybe even a caregiver who's in that situation now?
Sadly, there is still that thing that if a boy child has not started speaking at a certain age, the misconception is that it's a boy. Boys develop later than girls anyway. Or no, it's a child, it's an only child, and therefore there were no other children to be having conversations with. That why that the language development has also been late. But as a parent, you have a gut instinct, and yes, you'll have the elders who tell you that things are supposed to be like this. One of the conversations I'm always having with my young moms is, for instance, they like to put a bandage on the child's stomach. They say that the umbilical area has not healed yet.
Oh yes, I know that practice.
I call it the figure belt. And every time you have to tell them that, mommy, this is not necessarily a good thing for the baby. She says, no, but the elders say. I'm like, the elders may say what they say, but you as a mom also have a gut instinct. You know your child better than they do, even if you have not had many years, because they'll tell they've got the experience of having raised hundreds of other children. You as a mother also know what is right for your child. So unfortunately, some of them are guilted with that whole, if something goes wrong, I'll be to blame, and they'll
I didn't listen to the elders.
But if you feel that you're not sure about something, God willing, you have a relationship with your pediatrician, and you're able to take your child to your pediatrician, let them examine the child, because the child is supposed to be attending the Well Baby Clinic, which is what they offer in government sector, at least in the first year of life. They're supposed to be going there monthly for the weighing ins and everything. And that's also a time when we also check the milestones if the child is developing appropriately. And if anything is picked up, then at least early intervention is very good, and some kind of referral can be made for the child to be seen by somebody more specialized.
Interesting. Yeah, some of these practices, I mean, I grew up knowing that, something, a bandage must be put on a child.
A bandage must be put on the child. When the child has got hiccups, you put a piece of paper there.
Yeah.
There's a lot of things.
And you know, is obviously we acknowledge indigenous knowledge, right?
Oh yes. And that's one of the things that I also implement in my practice. Because when you come from medical school, you've got all these things. When you get to the community level, you encounter parents who've got practices that they do. There's also obviously usually the first point of entry into the health system is via the traditional healer. So it's not the patient is not going to come to me as a medical doctor. They're going to go to the traditional healer. And over the years, we've tried to empower our traditional healers as well to be able to recognize some of these signs. And when they see that, okay, yes, granted, I am able to make some kind of a spiritual diagnosis, but I think also medical intervention would also, work together. So instead of working as opposites, as that one is better than the other, we find ways of incorporating what we know and we work together as a team. Yeah. And I've implemented this several times in my practice as well, where I've had parents that expressed their reservations about medical, but and I said, I do know somebody who is a traditional healer. Can I please refer you to them, have a conversation with them? Then please come back and let's have a talk about it. I'm not judging you. I'm not chasing you away to say that what you have heard is incorrect. I want you to take what they've also told you and let's have a conversation about it. And one of the things, so sorry.
Yeah, no. So the way what I was trying to look at, Dr. Tumi, I was referring to indigenous knowledge in a sense that I don't know how to put. I attend quite a lot of Department of Science and Technology events, and one of the things they've got an area of specialization called indigenous knowledge,
which is important.
Which is important, not so much on the spiritual side, but indigenous knowledge includes things like, our grandparents will know that, it's going to rain because they can see that they understood the signs of the clouds and the weather. They knew long before the clocks were invented, what time it is now. Like, we know the chicken goes off at 5 a.m. I don't know. So the parents or our great-grandparents would understand, some of the things.
But can I say something as well? I mean, look at our parents, look at our people today. You just started with the first line that says, the most Googled question is, does my child have autism? People are heavily reliant on those devices.
Western source of information. Yeah.
So it's like, I think even if they wanted to start trusting those instincts about themselves, they are already so bogged down with, but I've got easy access over here. So why don't I just confirm what I'm feeling
Dr. Google.
with what I can? And I hate Dr. Google.
Yeah.
But,
I hear you. I hear you. So this is a very interesting topic. Obviously, as you can see, there's a lot to unpack. Like there's definitely a lot to unpack. And if I'm thinking, when going back to indigenous knowledge, I'm just going to say this one thing. I'm thinking usually when a woman gives birth in our culture, there's the elders. I don't know what they call them, a doula.
Is it the ones who is like a midwife?
Yes, they take care of the woman and to clean your stomach and all that stuff, which is not a spiritual process, but there's a science around how you heal your back faster and things like that. So that's important indigenous knowledge around childbirth and things like that. So that's kind of like where I was rearing to when I was mentioning it initially. So, Dr. Tumelo, I know you talked about, Dr. Google, something you don't really, it's not your favorite. I can imagine you have a lot of patients coming through. No, Dr. Tumi, Dr. Google says. Like, how many PhD does Dr. Google have?
Dude, they come in and they even tell you, Dr. Google even says you must give my child this, that, and the other thing.
Yeah.
And I'm like, but the one thing you forget about Dr. Google, you ask one question and they give you 100 answers.
Yeah.
When you tell me what's wrong with your child, I am going to ask you a whole lot of questions because I need to filter out what direction are we going in here? What exactly what might be going on with the child, to get to a proper answer.
Yeah.
Whereas Dr. Google, my child has got a white speck in their eye. It might be cancer. It might be a piece of rice. It might be hereditary.
Yeah.
So there's a lot of things.
Yeah.
So being able to sit down with the mom, I welcome them when they come with Dr. Google. And then I'm like, okay, we're going to do this together. You give me the questions and then I'm going to go through everything with you. And break it down for you so that you understand why it is not this, but it could be this particular diagnosis. It's just very important.
Absolutely, it's very important. But what's nice about that is it means people are curious. but it's important to always go to the expert and understand, because you have seen countless of families coming through. You're able to give a correct information. So staying on Dr. Google. So parents are now Googling or wondering or searching. Now we've done the diagnosis. We know what's happening. What do they do next, Doctor? Where do they go?
So with regards to the assessments, there's the psychiatrist, there's the pediatrician, neurodevelopmental pediatrician or general pediatrician. There is the pediatric neurologist as well who are involved. And as I said earlier, that it's a multidisciplinary approach. So sometimes they can go to the speech therapist first, and then who then refers to the other people or the occupational therapist. And then after that, once the diagnosis has been made, now that's the tricky part for a lot of people, because before I even send a parent to go and, okay, now we've made this diagnosis, let's start with the therapies. I always advise them it's a journey. And in the journey, we're not just going to get in the car and then in 20 minutes we'll be in Cape Town. There's going to be a whole lot of stops. We're going to get lost a couple of times. Sometimes it's going to rain and we have to park by the side, and sometimes it's going to be very shiny. We're going to be celebrating. And then the minute we take, we drive 10 kilometers, there's a tire burst, and then we have to stop again.
That's so reassuring, Doctor.
We have to do it like that so that we also manage each other's expectations. Absolutely. And I've had parents who had children who are not verbal, who are not speaking, and then one day she comes, oh my God, my child just started screaming, mama, mama. I'm like, yay. 2 days later, oh, she's quiet again. And I'm like, that's the thing. It's a process. It's a journey. So we take every day as it comes. So I first start with that conversation, and then stressing the importance as well of mutual respect. Because if we're going to do this together, it's you and me. So you're not going to go and bring, hey, this person said that, or the prophet said this, and that other person. Let's have the conversation, and then I will advise you on what is correct and not. So once we start that process, I usually send the parents as well for some counseling, because it's a huge diagnosis.
Absolutely.
Any parent who's about to give birth, I mean, those 9 months of expecting, you have having dreams and fantasies about how your child is going to grow up and be this and do that. But now here you have a child who's completely different from what you had expected. So it's important that the parents or the caregivers go for counseling. And then after that, you involve the rest of the family as well, because there are siblings involved, there are cousins, there are relatives. And then our journey begins nicely. So we involve all sorts of therapies, primarily the speech therapist, the occupational therapist, and the doctor and everything. Because my part as a doctor anyway, it's also to continue to assess the child clinically to see if there's other conditions, and also if there's an indication for any kind of medication to be prescribed. This will also come in. So yeah, it's very important. But what we try to do nowadays, we're trying our hardest. It shouldn't be that a mom or a dad drops off the child at a school and then picks the child up at 5 in the afternoon. Because that's one of the things that I experienced early on when I started this. Parents wanted to let me just drop off the child at the school and then I'll pick up the child later. And then the thing is, when they do that, after 3 months, they're like, but this child is not getting better. And I have to explain that, but it's a process. So what they do at that school, you need to be a part of. You need to see what they're doing. You need to do it with them, and then also be able to do it with the child at home. So the type of therapies that we encourage, that we're trying to implement, are more naturalistic and inclusive, meaning that don't separate the child from their natural environment. Rather, use real life activities, play therapy, because there's evidence that it's evidence-based that play therapy also assists the child with in providing the therapies that they require. So use the child's natural environment, use the child's natural tools and toys, nothing expensive, to start with the therapy for the child.
I just like how you, it's a very comprehensive process. I like that you're recommending the parent themselves to get help, because we've interviewed quite a few parents and they talk about it as a grieving journey.
It is actually.
Yeah, and how important not having help means you are not equipped enough to, join the new journey of supporting your child properly.
It's funny how you should mention that it is a grieving process, because I also am a pediatric palliation graduate.
Mm.
So
What is that? The
pediatric palliation care. So
Pediatric
basically, it's
palliation
helping parents and families through that process of when a child has got a life-changing diagnosis or life-threatening diagnosis. So some people, unfortunately, they see palliation as a way of I'm preparing somebody to die, but it's actually preparing the whole family for the life that that child is going to have, and accepting that there's changes, you know, and looking at different aspects of that whole family, the dynamic, that is not just looking at the medical. There's the, you know, financial, there's the spiritual, there's also the mental. So incorporating all of that into that journey so that it is a peaceful one, and the support as well that goes long before, if the child does eventually pass, if that's the case, then that goes beyond
for those that are left
care.
behind.
But like I say, unfortunately, it's one of those subspecialties that it's gaining ground, but it still has some time to go. So I incorporate that pediatric palliation into this neurodevelopmental that I do, because I don't just make a diagnosis and say, okay, well, go sort yourself out. I do that whole holistic approach to, okay, what do we need to do? What realities, what modifications, what skills and tools do we need to look at that are going to be assisting us in this journey that we're now going to be on?
It sounds so empowering, literally, and I haven't heard it the way you have put it, Dr. Tumi, because you're looking at relatives as well,
yes,
the siblings.
Because when you leave your son or your daughter with your son, with your sister, when you have to go to the mall, and she calls and says, "This child of yours is rowdy and naughty. I can't handle this." It means they don't understand. They don't understand what a meltdown is. You know, they call it a tantrum, temper tantrum. It's not a temper tantrum. The child has got a sensory overload and they don't know how to process that. Therefore, that's how they physically display that. They don't know how to regulate themselves. So it is important that we don't just involve the family, the immediate family, but we even involve the extended family and community. And that's one of the things that I'm very proud of with the work that we've been doing in Mafikeng. Looking at some of the parents that I started off with and where they are now years later, and how you see them actually speaking to people in public or in the church, is telling them, my child is not throwing a tantrum, my child is having a meltdown. And I love how the communities are also open and saying, you know, I actually want to hear more about autism. And everybody comes together and helps out when you're at church with your autistic child. And they're like, okay, let's help you out here because we understand that your child is going to behave like this. Let's not treat them as if they need to be isolated. Let's also include them in the life and the worship that we're having.
That's such a powerful process. So if I'm hearing you, do all the pediatrician or your colleagues in the profession apply the same approach? Because
I pray they do.
I can imagine, you know, because most parents we've had, Dr. Tumi, that come here, like some of them say, you know, I can't even go to, when we get invited for family dinners at our friends, you know, I just don't want to go because I don't want to explain. And some say, you know, my relatives are saying my child is naughty. But your approach, I think, I forgot what you called it. The name is
palliative care, but that's also part of the respite care that we have there, because when you are in that journey, when you're in that situation, it's a 24/7 job. So there are times when you also need to just, can I just have a little bit of rest without feeling guilty that now I'm abandoning my child or I'm abandoning the situation. So respite care is now where you have other people who can offer you that relief through the support that they also give you. So when you go to church or when you have to go to an event or when you just need to take a nap because you're also exhausted, then your sister says, bring your child over, let me look after the child. Or the grandmother also understands. When you go into the malls with your child, people shouldn't look at you with the wicked eye because, oh my gosh, how can you be behaving like this? You know, they should be offering you the support in the shops, in the malls, and everywhere. And I remember an example where there was a young child. He was about, I think he was in 14, 15, but you know, these extremely tall young boys who look like they're 20.
They grow up really fast.
And this child, his way of regulating himself when he seems to be out of
overstimulated,
meltdown, having a meltdown, was to reach for his mother's breasts. That made sense, and that's okay. That made sense to him. But one day they happened to be out. They went to a mall, and you know how it is when it's around festive season. There's a whole crowd. There's a whole lot of smells and sights and sounds for our children. So they're overloaded. And somewhere along the way, he got separated from his parent. And when he got separated, he needed to calm himself down. And unfortunately, he reached out for the first pair of breasts that he could find. But it didn't end well because some people still don't understand what this is. The lady that he reached out to was with her boyfriend, and the boyfriend assumed that the boy was being naughty. So they end up beating him up because he thought this person is violating my girlfriend. And again, that's something that's also something we'll have to talk about, where some of these children are criminalized. In the community, this child is used to eating whatever he finds. Now, because he went to the neighbors and he started eating the food, the neighbor thinks this child is being naughty, he's being bad, and then rude. They end up punishing the child. So those are some of the things, and we stress the importance of increasing awareness and teaching people so that they understand. If this little girl comes up to you and grabs your sweet, it's not because she's being naughty. That's her understanding. So therefore, be patient with that.
Wow, so we need to hear more of this, Dr. Tumi.
And I suspect on your beautiful platform, you're going to have a lot of people telling you about it.
Absolutely. I'm looking forward to hearing this. And I just like how you're normalizing, because one of the parents on the show did talk about it, that, going to the mall, my child being hyper, everybody stares at me, but empowering the whole community so that when they see it, they can be that support for the mom who also feels overwhelmed, right?
I love how Prof. Petrus always says, he's Prof. DeFries, sorry, his last name is DeFries, always says, who's normal nowadays? Who's typical? Because we all want to think that somebody who's behaving out of the norm is, neurodiverse. But who's normal? What's the definition of normal?
Yeah.
So
once
we get used to that, you're not going to be opening, surprised when you see somebody who responds or behaves a certain way. That's how we're going to start accepting each other.
Yeah, with awareness. It's funny that you say that, Dr. Tumi, because I think 3 weeks ago we had Dr. 𝐻𝐵𝐶. She's a medical doctor heading up some big hospital. And we were talking about, she's dyslexic and her daughter is also dyslexic. And as we were talking about it, she talked about maths, because she's looking at neurodiversity as not something to be accommodated, but something to be facilitated. You must watch her episode, very insightful. And then she says, who's to say that the way you're looking at the numbers are correct? Why can't you see a 3D, that they say 3D to number 1?
Exactly.
Right? So she's, in essence, questioning what is actually neurotypical.
Exactly.
To the point that you're speaking. Dr. Tumi, you talked about what we know about you is that you're also a disability advocate. You advocate for the rights of those who are differently abled. And I know earlier you also talked just a little bit about the private and the healthcare system as far as getting support is concerned. What's the difference between the two? What's the waiting period? What are the costs?
First of all, in public sector, obviously we have a referral system. So a child presents at primary health level, most likely at a clinic or at a health center, and then they are usually referred to a district hospital, regional hospital, and then eventually to tertiary if there's an indication. So from moving from primary health all the way at least to being seen by a pediatrician in regional can take some time, because obviously the volumes are large. So you can have a child, the teacher picks up or the mom picks up that there's something wrong in January, but the child will only probably be seen in like August or September because of the long waiting line. And also not just after not with just the assessment and the diagnosis, but also after diagnosis, when the child now has to be seen by speech. A lot of the times, ideally, the child should be getting speech therapy or occupational therapy weekly, if it is even possible. And we know in our public sector, it can take up to 3 months from one session to another session. And that's why I always encourage parents that when you go to those individual sessions, try to learn as much as you can that you're also going to be implementing when you get at home. Then we look at resources that are available for the assessment and the making the diagnosis. What is available, what is working, what is not there. Then, of course, the specialist as well, whether you have the appropriate skills, you have the relevant or appropriate practitioners in those particular settings. Rural suffers more than the urban areas. So rural sector, you can even have a child mismanaged because of such. Then you look at the private.
Before you move to the private sector, Dr. Tumi, we've had an educational psychologist that talks about the waiting period just to get an assessment.
Yes.
And I can't help but think about, the longer you prolong, for this child to either maybe to be assessed means
the later the intervention.
The later the intervention. But most importantly, for those that are in school, this kid can't get a scribe. They can't get access to the support that they need, and what that does to their self-confidence.
Can you imagine a child who grows up knowing that things are not working as they should? Because being diagnosed with autism spectrum disorder or ADHD or any of those other conditions such as dyslexia doesn't mean that intellectually you're not able to function. So the frustration that comes with that, the anxiety, obviously now because you're not responding the same way or the way you should in a classroom, maybe other children bully you. I mean, we look at our public sector as well, the schools, there's so many children, the teachers are overwhelmed, and sometimes attention is not given appropriately. So it does cause that little bit of frustration for both the child and the parent as well, because some of them don't even know, what am I supposed to do? Where am I supposed to take this child? How am I supposed to get the child into the system, and what is wrong with the child? This child is being naughty. We know what happened with the naughty kids.
They get beat
naughty,
sometimes.
They just get beaten, and then you're wasting time in school. Let's just get you out anyway.
And that damages them.
Self-esteem and all sorts of things. And then that's where now you get the child also now getting into different activities that are very inappropriate.
And what I love about your approach of getting the committee on board and making sure that the parents themselves understand you can't just drop the kid at school. Because in one of the episodes, we had a parent, and you can feel the weight on this parent, especially a single parent, to say, she said in some of our conversations that I dropped my child at school. I get called every now and then, come fetch your child is behaving. She was totally overwhelmed. The amount of travel, getting away from work, the emotional toll of it all.
You know, one of the things that I also noticed was that the difference between the haves and the have-nots as well. With the have-nots, when you have to drop off the child at school, you have to drop off the child at school because you have to go to work. You cannot go to work. Where are you going to get the money to provide? Whereas in those families where they seem to be a little bit well off, the one parent can afford to say, let me stay at home and also take care of this child. I've seen, some families where the one parent decides, I'll take the child to the therapies myself and do the therapies with the child. I'll take care of the child's therapies, the well-being, you go and work, the other parent go and work, and you can continue to provide for the family. And it's heartbreaking. I mean, being somebody who works with both groups, I won't lie, it's heartbreaking for a practitioner you feel guilty, actually. I remember at some point thinking, how am I supposed to even wear a labeled something to show that I can afford it when I know that the people that I'm serving, they struggle to even just put the basic foods on the plate, on the tables. So it causes that inner turmoil for us as well. And that's where we fight as hard as we can to have the system provide proper quality care and service for those that cannot afford to go into the private sector. So and unfortunately now when we have the discrepancies. You said earlier, South Africa is a developing country. It's a very funny country. You've got a mixture of developing and developed.
Absolutely.
And we're coexisting. But at the end of the day, when we each go home, our situations are very different.
And it's interesting that you're feeling the toll of this discrepancy in your practice run.
I've been feeling this for 20 years of my work life. So.
I can imagine, how much that moves the needle, because when I listen to one parent talk about, what part of what you're touching on, I felt the weight of this parent. I don't see her every day. It was just a conversation. I literally felt the weight of this single parent going through this with the resources and the amount of money it costs. So I'm hoping at some point we'll have some kind of rectification process, because you talked about the public sector, and in the private sector, there's a lot of resources.
Well, in the private sector, there are a lot of resources, but money as well can be an issue. A lot of the medical aids still don't recognize neurodevelopmental conditions as chronic disorders. So you exhaust your medical aid a little bit faster than the average person, because you have to pay for the therapies and all of those things. And yes, we may have the resources, but accessing those resources can still be a challenge. And or even finding the appropriate practitioner to assist you can also be a problem. So even with that, I still advise those parents as well, please make sure that when you go for the therapies, don't just sit there and let somebody do the work. Learn as well and bring back to your home, which is why I mentioned the naturalistic approach or a naturalistic therapy for the child. Using what you're learning, incorporating that into the everyday living environment of the child, so that it doesn't feel like therapy. It feels like, you know, growing up with your child. And that's from assessment. Assessment might be a little bit quicker because maybe there might not be such a long line. But assessment, therapies as well, affordability, different medical aids, different medical aid plans, exhaustion of medical aid. Now everything has to come out of your own pocket. So that might still be an issue. So
sure. Yeah, this is a very important topic, because we've had I think a dyslexia expert talked about this, and a few parents. And what most people are upset about is that, you know, medical aid covers biological, you know, I think lifestyle conditions like high blood pressure,
hypertension and diabetes,
but something that's neurobiological is
chronic, and because they still haven't yet classified them or they see them as chronic conditions, it's taking its toll on the parent or the caregivers.
So there needs to be some kind of a policy adjustment, actually.
Yes, there needs to be an overhaul of a lot of things. A lot of things.
Yeah. Also, without digressing too much, while I was at the airport today waiting, I overheard this middle-aged couple. I think they're Africans, both of them, and as they were talking about ADHD and insurance, and how insurance classify them as high risk, and so the mom has, I won't give too much details because I've invited them to our podcast, right? So you will probably have to wait to get to hear her perspective in totality, so you're not hearing bits and pieces. But it was fascinating listening to this couple talk about, you know, how the health, you know, the insurance sector is classifying them as far as risk is concerned. So this, and when I interjected, I said, sorry, I just can't help. But, you know, I want to hear more. But also it's interesting the way the insurance sector is looking at the matter. So to your point, there needs to be an overhaul of different sectors of our society.
Yeah.
As far as
I mean, at least the relief that they seem to be offering is that, you know, for instance, in with certain lower socioeconomic people, there is the SASSA grant that is offered, provided that the diagnosis does fall within the appropriate group. And then for those that unfortunately are above a certain level, then there is, you know, some relief that they can have from, you know, SARS and stuff. So at least there are those little things that can help. But yeah,
we should, you know, we're grateful, right? But I think there's still a lot more that can be done.
There's a lot of work to be done.
Yeah, and thankfully we have people like you. I mean, I can't wait to go to Mafikeng and hear all these grannies talking about
Mafikeng, the wonderful place called Mafikeng, the capital city of the Northwest Province. Where everything is happening.
Oh, where everything is happening, right? Not in Joburg, what is it? The economic hub of Africa? Not in Cape Town, the world's best city, in Mafikeng. That's where things are happening, right? Yeah. So, Dr. Tumi, as we come closer to wrapping up, the parents have now done a diagnosis, and you know they understand what's going on with the child. What therapies are actually working? They might be asking.
So with
what works in South Africa?
You know, with the straightforward autism spectrum disorder, remember again, as I mentioned earlier, it's a spectrum. So there's different presentations within different age groups, within different people. There's no two people on the spectrum who are identical. So there is that, but we also need to assess for comorbidities. There could be other neurological conditions. For instance, you can still have a child with cerebral palsy and be on the spectrum. You can have a child with autism spectrum disorder, and just trying to think of examples right now.
Yeah, like some have dyslexia, but they also have autism.
So the therapy will be guided by what the child has or what symptoms are prevailing on the child. So with just generally behavior modification, or at least therapies that assist with the child's behavior, the child's ability to learn, are what we focus on. There's so many things that are always quoted, but
maybe you can cover in school. Is there support within the schooling system, either mainstream or inclusive?
Right now, I think there's a campaign for inclusive education, meaning that you're trying to have a child stay in a mainstream school, but provide the necessary support for them to be able to function. This is where you provide a therapy that is just for that child. Assisting that child, be it speech therapy, occupational therapy, educational psychology therapy, and all of that. But like I said earlier, we try to make it as inclusive as possible, not just in the child's school life, but also obviously in adults in the work life and things like that. So there is the non-pharmacological and the pharmacological part. With the non-pharmacological stuff, that's where, again, we talk about the therapies that I've mentioned. It is very important that they do participate in those therapies. So sometimes you may find that the child is unable to and may benefit from having medication prescribed. And there's different medication depending again on what the presentation is. For instance, there's an atypical antipsychotic that we prescribe that helps to calm the child down, because parents panic and say, "Oh, you're going to dope my child." No. The idea is to try and help the child to manage their challenging behavior. We're not trying to change them and make them, sleepy. We're just trying to assist them so that they can be more receptive to those therapies that I have mentioned. So there's different therapies.
I'm so happy, sorry to interrupt you, Dr. Tumi, when you're talking about this, because we do robotics and coding, and we have a project called Robotics with Neurodiverse, and we work with learners that are neurodiverse. And I remember quite a few parents actually who ask, I give my child a dose of Ritalin from morning so that they can cope at school and focus.
Benidate that's given for attention deficit hyperactivity disorder.
Yes, and so now we see them later in the afternoon. They say, "Do you mind if we don't give up my child, because I just don't like the way my child is. They're like a potato, just for a lack of a better word." So the parent is seeing this effect of medication on the child, and sometimes they don't want to give the child as prescribed or according to the frequency that the child is supposed to take. And so this kind of speaks to, some parents, I don't know how to put this, but some parents feeling, I don't want my child to be on medication.
I don't want my child to be a zombie.
There we go.
So that's one of the things that is important when you speak with the family. That if we have to now get into the pharmacological part now, where we have to prescribe, this is the medication that is possibly indicated for this particular presenting symptoms. These are the potential side effects that you might experience, that the child might have. But we need to communicate regularly so that you tell me if you feel that the medication is appropriate or not appropriate. As it is, having just a normal person taking antihypertensive medication like an adult or even a diabetic who has to keep injecting continuously, constantly, we know that we struggle to get them to adhere, to be compliant. So what more for a child now who has to be on medication and, but what I've had, like for instance, where a mom believes that, no, I don't want my child to be on that medication, where you prescribe the methylphenidate that you mentioned earlier, and the child starts the medication for a month or 2 or 3. Now, remember what I mentioned earlier, the costs.
Yes.
It doesn't come cheap. They have to get a script monthly because it's a tightly regulated drug. And after the 4th or 6th month, the mom decides, no, I think I see my child getting better. I'd rather not continue with this. Then they'll disappear for like a few months or a year or 2. Then suddenly, year number 3, they pop up again and say, my child has been begging me to come and bring him here because that medication was actually quite effective. So it's important to always ask the child as well how they feel about it. Remember, children are not little adults. They are also individuals.
Absolutely.
So you need to converse with them as well, especially, depending on the level of understanding. Are you okay with this? Do you understand what your diagnosis is? Do you have anything that you want to ask me about? And make it a comfortable, open, two-way, mutually respected.
Absolutely. You are the child. You listen to what I have to say.
We don't delegate. We don't speak at the child. We come down to their level and communicate with them. And also, I guess this also brings me to the therapy that one of the therapies that I've been involved in. It's called the caregiver skills training that has been implemented by the World Health Organization. It's already been piloted in a whole lot of countries in the world. But it did come to Mafikeng. And actually, let me take a moment to also shout out that it was piloted in Mafikeng.
Wow! In South Africa, it was piloted in
Mafikeng. So
now we know why Mafikeng is important.
Dr. 𝐂𝐿𝐴 for being a part. She's actually the one who's the driving force for it.
That's amazing.
So now, obviously, a whole lot of centers around the country in different provinces have also found out about, or are also learning about it and finding ways to implement it. It's not something that you have to pay 100,000 somewhere. It's readily available. They've even made the online program as well, so that every person can be able to access it and be able to use it, implement it. But basically, the naturalistic approach that I told you about, where we first thing on that, as part of the training, is that you have to come down to the child's level. So no more standing on top of the child and giving instructions like that. You kneel down and you come to eye level with the child. And that's where now the medication as well. So when the child tells you, I don't like this medication, it doesn't make me feel nice, you explain to them what's the medication about, what it is for. But if they're not happy with it, what can we do to modify, or what can we give as an alternative? Because remember, we're not trying to change them to be normal.
That's right.
We're trying to help them to
cope.
Cope with all the stimulants and everything that is happening, so that they can also understand and be able to,
to navigate through life. I'm so happy you mentioned this, Dr. Tumi. So don't worry at home. We will share some of the links and how you can contact Dr. Tumi to understand about some of these interventions and how you can get hold or get access to them. So so we'll just share information. Experts like this.
There are so many of us.
No, we have different experts, Dr. Tim, but they're all different in the insights we bring. And I think it's important to mention we have a lot of white experts. Yeah, so it's nice to have a native perspective as well. Our local perspective. I wanted to just touch a little bit on what you talked about. You said, I think you said, non-pharmaceutical interventions.
Yes. Every parent that I usually, when we make the diagnosis, I talk about this, the pharmacological and the non-pharmacological intervention. The pharmacological would be the medication, whatever is indicated for that particular condition. But the non-pharmacological stuff would be therapies such as, let's not do screen time. Let's remove screen time. Sometimes different diets are helpful for a child with ADHD. Supplements, omega supplements for the child with, attention deficit disorder. Those are very important in helping to support the nervous system. So those are the although you might say the supplements are pharmacological, but non-pharmacological things. So that it's not that they rely heavily on the medication, but they will also find ways of changing lifestyle modifications within the family unit that help the child to also accommodate or be able to function appropriately, because every child has the potential to be great. Nobody's going to snuff that out simply because of a diagnosis that they don't understand.
Yeah. So I love that part, because we do celebrate neurodiversity, and I like that you touched on that. But what I like about what you've just said, Dr. Tumi, is that you're kind of almost saying, it's not just a medical approach.
No.
We could try both and see what works best. And it also brings me back. We had Dr. 𝐂𝐵𝐵 from Potchefstroom University, and he talked about, shout out to Dr. 𝐂𝐵𝐵. He's amazing. He's the president of the Kinetic Center. Yeah.
At the university?
At the university. Okay, I need to look at you. So I love what Dr. Herpa said. So he's the president of the Kinetic Center at the University of Northwest in Potchefstroom. And he talked about the power of movement.
Yes.
I was intrigued, unpacking how he said your body is a living pharmacy.
Yes, I mean, it's amazing what you can release just by learning to move your body in different ways. So that's where now the play therapy comes in, especially with regards to neurodevelopment, that some of the therapies that you do, some of the activities that you involve yourself in and the child as well can actually help them to manage their symptoms a little bit better. There's a doctor, she's an old friend of mine who also wrote an article about how children who skip the crawling phase. I think she was an OT, or she worked with OT people, occupational therapists. And they realized that children who skip the crawling phase, because you know how every parent buys that walking ring. The child goes from sitting to the walking ring.
Yeah, I had a few walking rings.
That actually might affect the child's tone. And that's how some children actually are at high risk of developing ADHD. I mean, a simple thing like that. And I mean, I tell all my parents, you must burn that walking ring. You don't need the walking ring. But something like that, where a child who has just a higher than normal tone, and it will be a subtle thing that you wouldn't see very well with our naked eye. But because of that, that increases the potential of that child not being able to sit still because they need constant movement and fidgeting because of the tone that is elevated. So can you see how certain things, lifestyle modification, can actually have an impact on the child's ability to learn and certain things like that?
I'm so happy you're sharing this, because that doesn't cost a thing. That knowledge.
It doesn't. I mean, all you have to do, God willing, is have somebody who's willing, who reads the stuff and knows some of this, and is able to share it with the parent.
Yeah. As we're closing, Dr. Tumi, something we care about, and part of the reason why we do this, or the main reason, is to celebrate the strength that lies in neurodiversity. Do you have examples of maybe some of the people that walk through your practice where you're like, this person has something special that maybe the community doesn't always see? You always see a child who's tapping their foot all the time, being disruptive, but there's much more to the child than tapping their foot.
As in, you want me to
the strengths, So just when we were in Joburg recently, we talked to a parent whose child, I think, is 6 years old. His name is Riley. She's going to be on our podcast as well. And she talked about how the child was always busy in the class, and the school where he was going couldn't fully support him. And she went and did an IQ test of some sort, and they found that the child is gifted.
When you mention something that makes a child different, or something that we tend to not see, Autism South Africa had an auction where they sold a drawing by a guy called Stephen Wiltshire. He's an autistic person. He's an adult on the spectrum. And his gift is his ability to look at something once and then duplicate it in his drawings. And that's some of the things that the assumption is always, if the child is not speaking, or if the child is not behaving like the other children, then most likely the child intellectually, they're not on par. But we know people that have got the most outstanding IQ, yet they do not have conversations. They do not behave that the other neurotypical people behave. So I've got a few kids in my practice that I see, and it's so amazing when the mother is so tired or frazzled that they don't see that part of the child. But when we engage, because with children, you cannot just talk to children. Are extremely intelligent.
They're very intelligent.
Extremely intelligent and perceptive. So when I start engaging with them, and then that part comes out, and the mom's like, "What?
And child is this?"
Yes. These are some of the hidden gems that our children have. Every child has the potential to be great. We just have to know how to unlock it for them and give it to them, so that we can't shame them. We don't shame children. We don't guilt trip them simply because they're not doing what we want them to do. You can't hit a child. You can't say the child is naughty.
It's not.
You have to allow them to lead you in the direction that brings out their full potential.
I just love that you've said that, because one of the things, that we say about intelligence is that it's a complex subject, right? Intelligence is varied. It can't just be academic. No. It could be artistic. It could be, the ability to sense people's emotions. And when you're talking about art, this was made by Autism Western Cape. That's where we bought it, by somebody who's neurodivergent. Nice. So it shows there's lots of strength in different forms of intelligence in different people. Thanks for sharing that with us. How can people connect with you, Dr. Tumi? I know you're based in the mighty and the special Mafikeng. Yes. Do you do virtual consultations? Are you available online?
I'm not yet comfortable with virtual consultations, and I always tell my parents that when I have a consultation, I like it to be 30 minutes long. I do bookings. That way I have time with you. So I usually try to limit it to about 5 or 6 patients a day. Where I am able to sit comfortably, take a proper history, but also the interaction also gives you an idea of how the parent is or feeling, and because it's not just the child that we're managing, it's the whole family as well. Absolutely. So I am available to come and chat. I am available to share my time. Consultations, I have an office in Mafikeng where people come through. I work with a beautiful team in the Northwest as well, and I'm proud to actually say that there's several people from the university as well that we're involved with. I mean, we're also trying to set up structures in the province, because people generally have to drive out to the urban centers, but that's far, and the waiting lists are very long that side. So yeah, I've got a website.
Yeah, you have a social media. You have an Instagram where you share your insights.
Yes.
And don't worry, we will share. We will share those links so you know how to reach out to her. And and what we're hoping for is that she'll come back and unpack some of the topics we're really curious about.
Oh, most definitely.
And some of them include, how parents can survive the holiday season. Ooh. And there's one that popped up. We are apparently going to travel to Durban to talk to Dr. I don't know if it's Dr. Rahbi or who, about, how the prenatal care, whether prenatal care is one of the contributor to people, to children becoming neurodivergent. It was fascinating when we were hearing it, because we understand it to be just purely genetic. Yeah, so hopefully we will get to unpack some of these topics with you in future. So thank you very much. Dr. Tumi, thank you so much for coming through today. The way you've unpacked this topic of autism has really been such an eye-opener, I know, for many parents at home, especially hearing from a local context, because more often we hear about it from the Westerns who share their own perspective and their own experiences. But hearing it from a local expert, it's just so comforting, but also very encouraging for most parents, because people can relate to what you were saying. So I want to thank you from the bottom of my heart with the insights that you have shared, and you have given a lot of hope to a lot of parents that often feel overwhelmed, they feel sidelined. But the way you have literally not just given us medical advice, you've given hope. And I want to thank you for your time.
Thank you. Thank you to your team, and thank you for this opportunity as well.
Thank you. To our viewers at home, this is Beyond the Box. Please remember to like, to share, and follow. Remember, continue celebrating neurodiversity.